Hello friends, in my last video I have discussed about diagnosis and management of PSVT. Today we are going to deal with few questions about PSVT. So question number 1 goes like this. 40-year-old female intraoperatively develops heart rate of 220 and BP of 70/40. ECG shows QRS complexes that are less than 120 milliseconds duration. So what is the best line of management? Option A is adenosine, option B is verapamil, and option C is DC cardioversion, and option D is beta blockers. So if you analyze this question, there is a middle-aged female who develops heart rate of 220. There is extreme tachycardia and BP is 70/40. That means patient is unstable, and she develops narrow complex tachycardia, narrow complex regular tachycardia, and when patient is unstable, we directly go for DC cardioversion. We don't try any drugs. So here is the DC cardioversion is the answer. So since patient is unstable, we don't try any drugs. So whenever PSVT you make diagnosis, you just have to check whether the patient is stable or unstable. If the patient is unstable, you go for DC cardioversion. If the patient is stable, you first do vagal maneuvers. If it doesn't work, then you treat with drugs. Like, what are the drugs that are used in PSVT? You remember one mnemonic: A, B, C, D. A for adenosine, B for beta blockers, C for calcium channel blockers, and D for digoxin. So for detailed management of PSVT, you watch the video, which the link of this video is given in this description. Please watch that video. And whenever you encounter a narrow complex tachycardia, how to diagnose that condition? So you just have to see whether the rhythm is regular or irregular. If the rhythm is irregular, you are looking at maybe atrial fibrillation or multifocal atrial tachycardia or atrial flutter with very variable block, which is very rare. So mainly atrial fibrillation and MAT. So you are having narrow complex tachycardia, but rhythm is irregular. So atrial fibrillation and MAT are the two common diagnoses, differential diagnosis. And what if the rhythm is regular? It could be simple sinus tachycardia or atrial tachycardia or junctional tachycardia, where P waves will be there. Here in junctional tachycardia, P waves will be retrograde or inverted. In atrial flutter, sawtooth P waves will be there. And in AVNRT, there are no P waves. If P waves are present, it will be retrograde in 2, 3 AVF and V1. AVNRT also same thing. So this is the diagnostic approach for narrow complex tachycardia. So let's look at one more question. Question number 2. 25-year-old male presents with sudden onset of palpitation and pulse rate of around 115 beats per minute, which shows tachycardia, and BP of 110/70. ECG shows, the ECG is given here. This again shows narrow complex tachycardia. See, QRS complexes are normal, less than 120 milliseconds, and there is tachycardia around 2 boxes, means 150. So narrow complex tachycardia, regular tachycardia, that means with no PVs, means it is a case of AVNRT, or simply known as PSVT. So once you made the diagnosis of PSVT, we have to see whether the patient is stable or not. So here the patient is stable, 110/70. And what is the best line, first line of management? Ideally we go for vagal maneuver, but option doesn't have vagal maneuver, so we go for adenosine. So before giving adenosine, we have to rule out any contraindications for adenosine. What are the contraindications for adenosine? The contraindication for adenosine is, absolute contraindication is allergic to adenosine, and if the patient is bronchospastic, this is a known case of asthma, we should avoid giving adenosine. And if the patient is hypertensive or he is having features of congestive heart failure, we should not give adenosine. So when do you metoprolol in case of PSVT? Metoprolol is a beta blocker. Beta blocker is given when you tried for adenosine and patient doesn't come back to normal sinus rhythm, and you tried verapamil but doesn't come back. I mean, calcium channel blockers you tried after trying adenosine, still the patient's rhythm doesn't come back to normal. That time you use beta blockers. Other beta blockers that are used in PSVT management are esmolol, propranolol, and one more is atenolol. So when do you use verapamil? Verapamil is used when you tried adenosine and you didn't get the patient's rhythm back to normal sinus rhythm. So that time, if the patient's LV function is normal, preserved, you can use calcium channel blockers like verapamil and diltiazem. Verapamil is used like 5 mg over 2 minutes. After 5 minutes, if the patient doesn't come back to normal sinus rhythm, you can use again one more 5 mg. So like this, you can repeat up to 20 mg of verapamil. Verapamil is a negative inotropic and it causes hypotension, which is not given in cardiogenic shock and heart failure patients. So drugs used in management of PSVT, you have to remember a mnemonic ABCD: adenosine, beta blocker, calcium channel blockers, and decoction. It's not necessary to use them in the same order. So hope you like this video. Please watch the PSVT management and identifying diagnosis and management of PSVT video, which is given in description. Thank you.